those of you who don't know me, so I'm gonna give first a brief introduction from my side so that you know who you're talking to. So my name is Barbara Wieland. I work at ILRI in the Animal and Human Health Program, and ILRI is one of the partners in the HEAL project, and I'm going to give you a brief introduction on the HEAL project and its partners and what we're trying to do with this community of practice. I would like to welcome you to this first webinar of the HEAL project community of practice. And as you can see, the HEAL project, before we embark on the seminar, I would like to give you a 2-3 minute introduction on the project and the community of practice. And those of you who are not speaking, can you please mute your microphones? Thank you very much. So the HEAL project stands for One Health for Humans, Environments, Animals and Livelihoods. And this is a project led by VSF Switzerland in collaboration with ILRI and CCM. That's this consortium of 3 organizations covering animal health, human health, and environmental health. So the One Health for HEAL project really is a development project that aims to operationalize One Health and through that also addressing key challenges in pastoralist areas in the Horn of Africa. So the overall goal is to enhance well-being and resilience of vulnerable communities in the Horn of Africa. And we have set up the objectives of this project at different levels of stakeholders that are involved. So that the first objective actually targets men and women members of pastoral communities to make sure that they are engaged in defining the solutions to operationalize One Health, and through that to address the needs and especially challenges related to accessing services that they need in regards to animal health, but also public health, and to help them to improve rangeland health. The second objective then really aims to develop and operationalize the context-specific, cost-effective One Health units as a service delivery model, and to see how they can best add value by combining services from different sectors in a meaningful way. But in order to also have impact at scale in the future, we also need to work on providing the evidence that these One Health units work and that they can be recognized as a solution. And maybe what we are trying in the Horn of Africa is not the only way forward. So there could be other possible solutions that might help to optimize what we are doing or what other projects are doing. And that's why we have set up this community of practice to actually be able to share best practices and have a platform for learning. And yeah, so this is where we came about with this HEAL community of practice. And in this, we will share key findings from the HEAL project, but we also want this to be a more joint initiative of different One Health projects and One Health activities going on in different parts of the world. So it's a way to share experiences, to foster learning across different projects, to make sure stakeholders are engaged, and we aim to have this community of practice as also very intersectoral, so that this will be sort of that we will have speakers from different disciplines, from different parts of the world, also coming from a different angle, so that we have different stakeholders being from the research side, but also really the people who work in the field on a daily basis, that we also bring in the perception of policymakers and also the perception of donors who are involved in One Health project. And we do this in collaboration with the ILRI-One Health Research Education and Outreach Center for Africa, so that we can join forces with this initiative as well. Okay, before we embark on the first seminars, I just have to make the disclaimers that this webinar will be recorded and also be made available on the HEAL website through the HEAL YouTube channel. And I just would like to remind everybody to respect opinions of others and to mute microphone when not speaking, and possibly switch off your videos when not speaking to save on bandwidth for those who might struggle with internet connection. And as has already started today, use the chat functions to ask questions. There was a question before on if it's possible to have other speakers. So yes, please. So you can contact Saba, who has sent out the invite, or you can also contact us via our website, which is onehealthforheal.org, and please follow us on Twitter as well. So with this, I would actually move on to our first speaker, and I have the huge pleasure to introduce Bassirou Bonfoh as our first speaker of this HEAL Community of Practice webinar series. And I think it's fair to say that Bassirou is one of the One Health pioneers in Africa. He has worked for different organizations with different project consortium and different parts of the continent, and through that has contributed to the validation of the One Health concept. Bassirou was the managing director of the Centre Suisse de Recherche Scientifique in Ivory Coast, and he's also the director of the ILRI-One Consortium, which continues to contribute to the scientific foundation of One Health. So it's a huge pleasure for me to hand over to Bassirou. And Bassirou, you just tell me when you want to move to the next slide. Thank you.
Okay, thank you very much. Good morning, everybody. I hope you are all fine. It's a big challenge for me to start these webinars addressing One Health issue in pastoral areas among all the actors of One Health, or all the actors working with the pastoral communities. So here we are going to, next please, we are going to share our experience, next slide, share our experience based on the journey we had with the concept in Africa, and how we try to address the foundation of One Health that will guide practitioners in the future. And we'll try to look at experiences that we have and the next agenda, because One Health is old but new in our environment. So we will address some of the challenges and draw some conclusion for next step. Next slide. Okay. As Barbara said, we are at Centre Suisse de Recherche Scientifique in Côte d'Ivoire, which is a research institution. And ILRI-One Aspire is one of the biggest programs in that institution. And we are part of what we call the DELTAS, the Development Excellence in Leadership, Training and Science, developed by the African Academy of Science with a consortium of funders. And we are one of the 11 consortia. And our specificity is that we are the only consortium working on One Health. And we want, from this consortium, to build the Pan-African research capacity in One Health. And we have started since 2009 in training fellows in the universities, and we have trained between 2009 and 2015 up to 38 fellows from master level to postdoc level. And currently we are having 70 fellows under training at the same level across Africa, East Africa, West Africa, and Central Africa, where we try to balance the knowledge between those geographic areas and between culture and between language. I'm very grateful that Professor Brian Perry is joining us. He is one of our scientific advisory board, and he's chairing the board since 2009. Thank you, Brian. Next. So, next slide. In the context in which we are working, we have a different context, going from urban area to pastoral area and also areas where we have a crisis. So you all know the condition in which the population are. We have rapid changes, different transition, be it epidemiology transition, disease transition. And in those contexts of change, including climate, we have a fragmentation of topics when we consider academia. We have fragmentation of approaches, methodologies, and strategies to address the problem in those communities. And in addition to that, most of the activities are looking at emerging and re-emerging diseases. But what we want to focus is the endemic diseases. When we consider pastoralists, they are still struggling with the endemic diseases. And this is where we want practitioners to not overlook the endemic diseases, but look at the endemic causes of their problem. And they are also facing a shift from traditional risk, for example, zoonosis, to modern risk linked to their behavior change or their contact with other population, other cultures. They are having a lot of problem if we look at the nutrition aspect, the health aspect. And that's why it's very important that as researchers and practitioners, we try not only to look at, not only to map the problem, but also to map the potential and existing solution, and targeting especially those people who are at the periphery, and we consider those pastoralists as at the periphery of the system, all type of system, including health system. And those population at the periphery are exposed to many other risks, including what we are seeing now in West Africa with terrorists, where those populations are stigmatized, and because of lack of services, lack of policy, or lack of the state in their area, they tend to listen to whoever come to talk to them or provide advice to them. So those populations need really that we address specific solution with them. Next slide, please. So in this context, we said, okay, since we have started, I have started my journey with Jacob Zinstag from Swiss Tropical Institute, Esther Schelling, currently at VSF, Mamad Bashir in Chad. This is when I made my first step of research in One Health after working with Vétérinaires Sans Frontières. And based on our experience from the health of nomad in Sahel, in Chad and Mali especially, in Central Asia, Mongolia and Kyrgyzstan, we have said, okay, what can we do to drive the One Health agenda? And as a scientist, we developed a project ILRI-One to start building the capacity of researchers, young researchers. We said next generation of researchers, because we consider ourselves as old generation. We have been trained in such a way that it's very difficult now to bring different knowledge together. So if we address the systematic thinking in the new generation, we can change things in the future. That's why we created the ILRI-One program. And currently we are running the 10 years of existence. And in that experience in West Africa, East Africa, we also collaborate with other network like OHRECA, working in universities, SACID. With this consortium, we have been working the African Institution Initiative funded by the Wellcome Trust. And the last couple of years with One Health One, of Africa embedded in the ILRI. So as you see, what we have been doing was focusing on education and research. So what we want now is to target our training, our research, and whatever we do to consider more practitioners and communities. And we are now developing a next phase of ILRI-One to address the practitioner and the community level. And I'm very happy that One Health RECA of ILRI and now the HEAL project can provide avenues for partnership and targeting pastoral communities. And what is very important for me that I'm seeing with HEAL is this collaboration between the research center and NGO that will work with communities. And it will be, for me, a very strong mechanism of addressing the problem in pastoral area. Otherwise, policy alone or health sector alone or researchers alone cannot do the job. We need to involve practitioners, day-to-day practitioners in One Health so that it can be more effective. That's why I appreciate the promoters of HEAL, and I think it will bring a very good outcome. Next, please. So after you have seen our journey, next, I just want to summarize my talk with this slide, and I will take a couple of minutes on that. I call it Pastoral Communities and One Health. This was a picture taken in northern Mali by Jacob Zinsta, and this was a picture on which we built the One Health concept. And we said, for example, the health or nutrition status of this child that you see on the picture in the north of Mali is an outcome of combined secure pasture, rain. It's also linked to the climate. It's also linked to the high milk yield for the household, what they consume, which is their main source of food. And it's also linked to their cultural rooted health seeking behavior, and then the access to health services or social services in general. So when you see this child, you can understand the status and see what impacts the health provision of that child. And the first area in blue is the pastoral code. What we call this pastoral code is how we secure the mobility of those people to maintain their livestock system, and how we help them to adapt to the climate change and to have a good pastoral, a secure pastoral product for their consumption. And this is the first step that can be addressed by some discipline or sectors, not specifically linked to health, but the outcome of this intervention can lead to good health. And the second component in red is that the community in which we are working with as pastoralists, they have their culture, they have their behavior and their perception that need to be taken into account. We cannot bring ready cooked services to them without considering their own perspective. And this is very important. And the health of this child also depends on the decision this woman or the parent will take, or they will accept or refuse, for example, treatment or vaccination. It depends on them. So if the negotiation is not done between providers and those communities, the culture barrier can lead to the non-adoption. Then you look at the status of the child or the pastoral community itself. They are vulnerable population, and as I said, they are at the periphery, and we need to consider them that vulnerable and address very specific attention to them. And the last aspect is how we build the health system or the social service, depending on the policy or the economies of the country. If the system is not considering those populations at the periphery, we may miss them, and they may become maybe pocket of diseases or pocket of problems. So that's why the construction of health system it's very important to do that. So if you look at the summary of this picture, we will see that all sectors matter, all discipline matter, but how can we combine that to have effective services? And our question there was, where is the intervention starting point? This was one of the questions we had in Chad. And who coordinate the process, and who cover the cost, and how everything will be assessed. And the experience we have from Chad was that those populations said when they were having different sector coming to them, they just say, okay, why not talk together and then come back to us with solution after consulting us. Next slide. And I give you the example of how we from that experience, we can drive the One Health agenda. So as a scientist, we start thinking on how to make this more rooted by science. So whatever we do in the practice, we want to look at the scientific foundation so that it can be very, very strong. And for us, transdisciplinarity is one of the scientific foundations that bring different type of knowledge. And we said to have One Health effective, all type of knowledge matter and need to be given value, especially the academic and non-academic knowledge. When we say non-academic, it can be private, community, from the health workers, from the government. And no matter which sector lead the process, it's very important to consider all type of knowledge. And the second area is to, after the knowledge, is to see how different sectors can combine their scarce resources. The experience we are having currently with the One Health implementation is that people just think, put different sectors, build cycles, and develop the collaboration and expect resources to come for the intervention. But we said no, each sector has scarce resources and deal with a portion of the problem of the pastoralists. So why not join the forces in addition to the knowledge to see what can be done? And this was the experience developed in Chad. And those foundations were developed in 2 books. The hand book of transdisciplinary research and the book on One Health, which is now translated in French. So beside those books, we have also massive open online courses on those 2 topics, One Health and transdisciplinary, that I advise you to look at. Next slide, please. So coming back to the transdisciplinary process, people like definition, and we always face problem of definition when we conduct training. People like definition because it's the base, but it's not very important for us to try to come with a common definition. Everybody, depending on the entry point or the objective, can have his or her own definition. But for us, as far as those definitions comprise 2 elements, one is the collaboration, and the second is the added value. And I always raise the issue that if you ask yourself, what do you lose when you work in silo or you are not collaborating with others, or what do you gain when you collaborate? So if you answer to those questions, we think that you can drive your activities toward a One Health concept. So there is a necessary condition, which is collaboration, and a sufficient condition, which is added value. And normally what we see is the first one, collaboration. Collaboration is developed, theoretical collaboration on, but on the ground collaboration is very difficult to achieve. And then the added value evidence is not provided. That's why we push practitioners to incorporate the added value aspect in their intervention. Next slide, please. Then this is an example that I draw from what we have in Chad, where the pastoralists, they are a community, well-organized communities. Each sector goes to them and tend to provide services. And as I said, they ask, after looking at their household or community's problem, then service provided need to take from there and develop services. Normally, we tend to develop the strategy or the services and come to the communities. That's why we said One Health is a deductive approach. It's not an inductive approach. It's a deductive. After taking into account the voice of the communities, developing, co-developing with them the intervention, after understanding their situation. And for us, it's very important, the term co-designing. Co-designing is very important because if they are part of the process, the adoption rate will be very high. So One Health is not a top-down or inductive approach. It's not only zoonosis and not only collaboration, but among others, added value from combined knowledge and scarce resources is very, very important. Next slide, please. So we have also to look at One Health as a long-term process. It's not one spot activity, it's a long way process. And if you look what we have done in Chad or in Mali since 2000, we are still there trying to fix some of the issues on the One Health approach. So we have what we call two components. The first component is the dialogue between local knowledge and the academic knowledge. And this dialogue is taking a lot of time until the communities understand, or the policymakers understand, or they agree during this dialogue what type of knowledge can drive the intervention. Then come the long process of adoption, which is not easy because the population need to be aware of the situation. They need to understand, have their positive perception, experiment, because they cannot experiment, adopt something that can put their livelihood at risk. And after the experimentation, if it's conclusive, the adoption is high. That's why if you look at the joint vaccination program in Northern Chad, if it was successful because the population have seen the importance of that. Next slide, please. So if you see, we said also One Health, as we are doing since 2000, is an agenda, unfinished agenda, because we need validation and generalization. And that's why I like the HEAL project, that will bring practitioners to see, to draw different experiences, and that will help maybe to move very fast. And you have seen, for example, the joint human and animal vaccination campaign in Chad. It's now almost 20 years, but no policy has been taken to see how to drive this agenda, even if the evidence of impact is there. We have also worked on, for example, risk with improved quality of milk in Mali, without addressing only the health aspect, but the incentive, the economic incentive to improve milk production. And there we have a very good signal from the policy where the dairy sector is to show you that whatever we are doing is not a short-term intervention or a short-term research, it's a long-term and we need to follow. But we should not also forget that there are new issues coming up. For example, the problem of mental health. We have conducted recent research in Ghana with the pastoralists, where we realized that the lack of good performance of veterinary services lead to the livestock loss and the anxiety of the pastoralists. So mental health is becoming a hot topic when we consider the loss of livestock and the threat that the conflict and the climate have on them. The nutrition and their diet also is very important, as we have evidence that the balanced diet can improve many other things, and we have to look at other potentials. Next slide. This example is, we always said rabies is one of the good example of One Health. And we know all what to do, and I always put this picture to show that we know all what to do, but at the end, the most difficult thing is the last mile decision from the decision makers to put funding for intervention that we know it will work. And we ask ourselves, why at some stage policy makers are not taking the lead? Is that rabies is not a priority? Is that is cost beyond the state capacity? So those are the questions we need to address and understand, not only from the community perspective, but also from the decision makers perspective, so that a dialogue can be maintained to see how best intervention can work. You can have a very good scientific evidence on an intervention, but if at the implementation side, nobody is putting the hand in the pocket, you will live years with your evidence and nothing will happen. Next slide, please. So with One Health, we have challenges, and one of the challenge is the system thinking, and we developed that. It's a collaboration, especially in the academia, where we have a department and silos, and if the system thinking starts from academia, goes to the practitioners, we think that something may change. The second challenge is the strategy. How do we build the capacity of practitioners? We have been building the capacity of researchers, but with the practitioners is something which need to be done. Most of the countries have started working on the national One Health platform, but at the end is something that has not gone for the step in the implementation in the communities. And the third issue is people. How do we work with people? I think the three challenges are key to be addressed. Then in the implementation of One Health in pastoral zone, which is now a big challenge, most of people are asking question how to better implement, how to make One Health to be operationalized, and it's still a big question, but we think that capacity on system thinking is very important. Leadership, ownership, or coordination of the intervention is important. So the sector that drive the activity or the entry point can coordinate, but we still have lack of evidence. And if you look at this graph, there are disciplines that are not well involved in the One Health concept, and we think that it's very, very important now to consider other discipline contribution in the One Health, for example, social science, anthropology, and economics. Those sciences can help first collaboration and can help to evaluate the added value, be it social added value or economic value. Next slide, please. So as we said, challenges in One Health, capacity is important, and we need to include other discipline. And what we are seeing is also a lot of initiatives of One Health. We have more than 100 initiatives of One Health, and we don't even know now who is doing what. With One Health initiative, we have different One Health platform for the same communities. So we have to start talking to each other, like Hill is doing with Horn, with OHRECA, with ILRI-One, to talk to ourselves and design a good intervention model for realization of One Health. We advise to move from zoonosis, a single approach, to more global health and the capacity of researchers, and to achieve visible health impact, we need also to take into account the local innovation and dynamics, have more effective collaboration, and better define the role and responsibilities of each factors. And we have other obstacles that are this thinking. And simple things can change people's lives. I was just saying that pastoralists have learned and developed mechanism to deal with their problem. And what we need to do is not try to create great things, but try to see what they do, understand what they do, and help to bring ordinary things that can add value to their life and the society.
Thank you so much, Bassirou. I think it was very clear for the need of co-design in order for One Health to have an impact on the ground. And I think you made very good points about the need for intersectoral approaches. So I think a lot of hugely important experiences have been shared here. So I don't know if people have any questions they would like to ask before we conclude this meeting. Were there any comments that have been made in the comment box?
Hello, Barbara. Can I make a comment?
Hi, Brian.
Bassirou, it's always wonderful to see you and to listen to your wisdom, and well done. My question is really, you raised it later on, but I think there's a great challenge amongst researchers to get the interdisciplinarity. So I mean, people tend to be in boxes. Then when you link that up to your delivery side, and where you've got under the influence of government departments, where they are also not only in little boxes, but sometimes they are little boxes that are not very innovative and not very creative, if I'm being polite. So how does one change that? So you've got researchers that are in their boxes and some change happening, and then the different government departments in some of those examples that you gave. How does one break that down? How does one facilitate that with this interdisciplinarity?
Yeah, thank you very much. I think before bringing, for example, the science and the policy together, we need first, within each sector, like policy arena and academic arena, to do a transdisciplinary work. If you look, for example, the way our ministries are set up, we end up asking ourselves, which ministry address the pastoralist problem? We can have, at one time in Chad, we proposed to have a ministry for pastoralists based on what they provide as income and revenue in the GDP. So this first step work needs to be done. But if it's not done, the model of platforms are important to set up. So when you set this platform, then you look at the academy side. And what I said, in the academy, we have also department and silos. And you don't have an interdepartmental organization that address interdisciplinary problem. We still have problem, and you know, Brian, we still have problem in the academia to consider One Health as science. And most of the students we are training have to remove all the transdisciplinary aspect and defend their thesis only in their discipline. So the interconnection aspect is not considered in our academia. So until we have from both sides this kind of combined knowledge, then a real dialogue can be done. because a single discipline cannot go and talk to the government on pastoralist, something like that.
Okay, thanks a lot for these additions. Very valuable. Are there any other questions people would like to ask? I think we can maybe give it another 2 minutes or so.
Can I come in?
Yes, please, go ahead.
Yeah, thank you. First, I wanted to congratulate Bassirou. Nice to see you again. I am Mohammed from Ethiopia.
Yes.
And this was an interesting presentation, and I hope we learn a lot from you. Just a very quick question. Next week, we have our second workshop on Somali Region One Health Task Force. As a new platform, what suggestion or any advice would you give us as a task force which is established here in Somali region in Ethiopia? Thank you. Over to you.
Yeah, very good. The task force system can be the second step after the platform that drives the policy. But what we always advise is that before establishing the task force, it's very important that you have the first discussion process with the communities where you will do intervention and have them on board or part of the task force. Do not develop a task force and then go back to them. You need to develop this task force together with their representatives so that they have a voice and also help you on how to guide or drive things. Is a very important condition for their acceptance of whatever you will bring to them.
Okay, I hope that was helpful for you, Mohammed. Any additions or any other comments? I see lots of people really very much appreciated your presentation, Bassirou, so lots of thanks yous, and I definitely would like to add from that. So thank you again, Bassirou, for your fantastic talk, and yeah, many claps from everybody. Thank you so much, and have a nice day, everybody.